Hello there, this is the fourth and final podcast that was recorded at Monash Partners Informatics and Patient Data Forum on Monday the 6th of Feb 2017.
One's got chronic disease and complex care. If they can crack that, they can have that one. That's Melbourne Uni. South Australia's one is actually disadvantaged populations for obvious reasons, Indigenous health, and politically hot area, and they're doing a lot of work in it. We have particularly put our hand up to be a key partner in that. But anything that we lead on is actually relevant across the whole of the academic health science centres. And I have to say, we have agreed on the presumption that we will get some funding. It's been agreed both with the MRFF team and with the other academic health science centres that 20% of the money that drops into the bucket will be kept for cross-system initiatives. So there'll be important areas like that. But the expectation for data, for example, might be that Adelaide has some interest in registries and they may work with us in some of those areas. Other groups have particular interest in Indigenous data set development, and so they may lead on that sub-area. So how we'll work together will come together in the final way we put the bid in with government. But definitely what has really brought everyone together, Matt, is the concept that healthcare improvement is a non-competitive space, and that this concept of the way we research traditionally often has to be competitive for our funding buckets and has to be around excellence, but we have to be able to transcend that when we're looking at translation and impact, and that's a really strong government driver at present.
So just in terms of funding, thinking of the lead this time round, future, and will that predicate where the money's getting split up on?
I hope so. That's the whole point. If you look at the MRFF, and I suppose that's the advantage of being the lead for the academic health science centres, and so I've been doing most of the work with the MRFF team, is that there's clearly going to be a lot of money out of the future MRFF that goes into data. And so if we're positioned to lead in that space, it's not going to be a lead that's rotated across the academic health sciences. If we're positioned from the outset, I would anticipate, especially if we've got university investment, potentially state government investment, the whole idea is we strategically position ourselves really well. Obviously data is relevant to everyone, and Melbourne Partners has a really strong interest in electronic medical data sharing, but they have all different systems. They don't all have Cerner, and they've got other challenges around that. So everyone's going to do it, but we're hoping to strategically lead it.
You said that there are some political dimensions, and clearly data has political dimensions. But with this being a priority of the MRFF, do you think there's a mood around for having a universal identifier or move to an Australia card?
There is, but there's also lots of fingers that have been burnt. I must say, I'm not professing to be the data expert. So whilst I'm positioning the university to lead on data, Jim looks like he's going to say something.
Chris might be able to comment further on. There is a universal health identifier. Done. Thank you.
But in terms of implementing it, my apologies. I presume that's what you mean, Chris, in terms of being able to actually implement it in a meaningful way so we can use it as a universal identifier. And indeed, I've spent a lot of time with Ronnie Potasnik, who was the lead on the national attempt to implement that, and the patient health electronic record. There's been lots of attempts at doing that. Yes, it's been challenged, but if the academic health science centres, who are the primary health services, and if we bring our primary healthcare colleagues on the way, could have a role in driving that agenda, which we possibly could, and we made it our problem to help solve, that would be massively politically useful. Sorry, just in case people didn't hear that, there was a question about whether we're going to progress the electronic unique identifier. Any other questions? Okay, thank you, Ian. So Ian said, if you want to email him, please do.
Thank you.
Great. Now, John, can I invite you to come up? So John is being thrown in off the deep end. He'll tell you. Can you tell us a little bit about yourself, John?
Yes, I can.
And then what your background is.
Sure. So hello everybody. So I haven't actually started at Monash yet. As of May 1st, 2017, I will be the new Dean of the Faculty of Information Technology. So I'm just here currently for a couple of weeks looking for good opportunities like this, and also looking for places to live. I'm currently at Lancaster University in the UK. If you don't know that, it's near Manchester. It rains a lot in Manchester. When I came to interview at Monash last September, it spent the whole week raining in Melbourne. They kept promising me that there is actually sun in Melbourne, so when I landed on the plane last night, and looked out of my window and saw nothing but horizontal rain. It was all I could do not to get on the first plane back to Manchester. But I'm still here. A little bit about my background. So I'm a computer scientist. I actually kind of made my career in software engineering research. Worked for NASA for about 7 years in California, and really trying to look at how can we build bigger systems with high quality systems that are robust. It was around the time that NASA was crashing lots of things into Mars, and a lot of those were due to software errors. So we put together a big research group on that. In more recent years, I've got very interested in the kind of whole area of digital health, and in particular health data. And a lot of the stuff that Helena was talking about in her earlier presentation about collaboration and partnerships from the very beginning of research projects chime very much with my approach to working. So a couple of years ago, I ran a big project called Catalyst that brought together about 10 different departments from my own university, all kinds of different disciplines. And we got community groups, industry, academics in a room and got them to decide on research questions and the approach to addressing those research questions, and ran it as a real collaborative partnership. A lot of those ended up in being health related. So we did stuff about kind of wearable devices to help people manage severe anxiety. We've done a more recent project looking at COPD and trying to use data to provide better decision-making, clinical pathways and things like that. So one of the reasons why I was really excited to come to Monash was because of the events like this and the opportunities that are afforded by, kind of being real world leaders in kind of health data analytics and healthcare. So let me just tell you a little bit about the Faculty of Information Technology. I'm not sure how many people do you think you know much about the Faculty of Information Technology? Who thinks they know it well? Okay, so we've got two. Ross is there. So that's my first challenge, I guess, is to get people from across the community to know more about the Faculty of Information Technology. It's a very broad faculty. We cover everything from kind of traditional hardcore computer science to kind of socio-organizational technical things. So in fact, if you ask somebody in my faculty, what does the faculty do? The answer you'll probably get is, we're very broad. But I think there's a clearer answer than that. I think we've really got key strengths in 4 areas. First of those is data science. So we're really becoming very well known in data science, and that includes things like algorithms, intelligent systems, machine learning, and all of that. We've got about 40 academics within the faculty that are working on data science. We've got a key group of people working in what I call innovation, so coming up with innovative new technologies, the technologies of the future, whether it's virtual reality, whether it's wearable devices, whether it's kind of 3D printing, that kind of stuff. We've got something called SensiLab that you might have heard of, and that group also does, they're leading the way in something called Immersive Analytics, which is about using virtual reality and visualization to help yourselves navigate better through data and understand that data better. We've also got a very good tradition in social and organizational informatics. So people like Suma Kemish are leading projects, and we've had philanthropic donations, for example, from Oxfam, doing research on, for example, how do you give victims of child abuse easy ways of kind of keeping a record of abuse incidents that are going on, because it's quite difficult after the fact to kind of reconstruct what the events leading up to a particular problem were. And we're growing now a big strength in kind of cybersecurity. So we're leading on something called the Oceania Cybersecurity Centre, which has got 8 universities across Victoria involved, and industry partners and the government. Now, the interesting thing, I think, for this forum, if you look at those 4 key areas, so data science, innovation, social informatics, and cybersecurity, is that they're all fundamentally central to health data. If you look, you've got the data science, which is how do you make sense of the data. You've got the innovation, which I think is really about the user experience of the data, which to me is one of the key areas that's missing. Lots of people talking about big data, let's throw some algorithms at it and extract knowledge from that data. But actually, how as human beings do we interact with that data? Data is actually quite an emotional thing, I think. Different people will interpret data differently according to what they want to get from that data. We only have to look at the President of the United States for evidence of that. So there's something about the experience of human beings interacting with data. There's the social technical side of things as well. Again, a lot of what Helena was saying, it's not about coming up with new algorithms and then pushing them out into practice. It's about working with communities from the very beginning to make sure that the problems are kind of jointly owned. And obviously cybersecurity, the whole issues related to kind of keeping data safe and privacy and what that means is very, very key. So I mean, for me, I think huge number of really interesting challenges here, challenges in privacy, ownership, challenges in how we can use data to do better decision making in a healthcare context. There's the scalability issue, how do we handle these large volumes of data, the user experience of data, how can we use data to allow people to self-manage conditions, chronic conditions, for example, the whole thing about kind of behavior change, it's all very well people talking about wearables and things like that, and often a lot of us have Fitbits and stuff like that nowadays, but that really is asking for a fundamental change in the way that people behave and act, and that's not a trivial thing to achieve. Medical apps and the regulatory pathways that go alongside that, the whole Internet of Things and wearable devices, and even the kind of ethics and values. One of my key interests, again, is what I call values-based computing. So, computing that has inbuilt into it a sense of the values of an organization or the values of a government or the values of an institution. You could say really that if you really get down into the nitty-gritty, that every line of code that a software developer writes has a moral and ethical implication. And if you look at the Volkswagen emissions scandal, that's a clear example of that, where that went wrong. So developing systems that will flag when key values are violated, I think, would be very important in a healthcare context as well. And that's a new area of research that I think would go very well with the kind of things that are of interest here. So I'll leave it at that, but just to say that I think, as a faculty, we're very interested in collaborating on these problems. We don't really, I think, have a pre-canned agenda, so I think the collaborative approach will work very well from us. One of my observations, we're interested in the digital health agenda more broadly, and certainly one of my observations, if you look at Monash and digital health, is there's a lot of stuff going on, but it's in islands, it's not well connected. And I think, one of my key agendas for my time once I joined, or even before, is to try and connect some of these islands together and have a banner so that we can be well known throughout the world in digital health more generally and in health data more specifically.
I think the other thing really to emphasise is, whilst we've had Ian speak because of the way the university is wanting to engage with many of us as researchers, and also John because it was opportune as he was here at the time, there's also very strong emphasis here on the fact that the health services collect and own the health data at the moment, whether that's in primary care, which is largely very important, but a cottage industry in Australia, bringing that together cohesively is very challenging, as opposed to the opportunities that we have with the larger health services. So the health services have a very strong role on the data executive, and so far in our meetings there's been a very strong emphasis on the fact that we need to know how. Anyone on the executive, please jump in anytime if you wish, but the big question everyone asks is how we do this, and everyone is asking exactly the same question. And without these sorts of platforms, everyone's starting to do it their own way. So what we're trying to do is draw back and avoid that approach, and ideally also influence that on a national level, so that actually we start to sensibly do things the same way, so clinicians and researchers can actually use that data in a meaningful way. Any other comments? Anybody want to, John?
Helena, one thing we'll have to give some thought to is training.
Yeah.
Because, in epidemiology we refer to judgment safe data analysts, and they're not all that common.
So, in fact, just to pick up on that point, I'll tell a brief story which I've told the health department many times, and in fact several people in this room told me the first time, which is that it's fine to say we're going to pull out health data and release it open transparently to the public, but the problem is that both the people who are releasing it and the public often don't understand the nature of the data. So one classic example is standardised mortality ratios across Victorian hospitals. And the state government, in a quick whim, announced that they were going to release the standardised mortality ratios to the public of every hospital in Victoria, with no understanding of what the data actually said. When you look at it, you would close every regional hospital in the state overnight because they were disasters, not realising that if you come to a large city hospital and you're in palliative care, you go to a palliative care centre. If you're in Bendigo, you stay there until you pass away. So, and the intern who's on at 2 a.m. writes dehydration as a cause of death, whereas it was actually palliation. So there are so many problems now with even the mindset of the people collecting the data and the people analysing it and the people releasing it, that we are millennia away from being able to transparently just release data. And in fact, that was a salient lesson for government. Unfortunately, everyone who learnt that lesson has turned over, and the new lot don't understand that at all. So I think that the real point here is judgment safe, the concept of the NHMRC and government has all come together and said it's a legislative requirement to share data. We should all share data for research, but often the people using it for research do not understand the circumstances under which it was collected. So one of the initiatives that we put forward, John, is actually to have some capacity building in data, in education around data. So basic education in undergraduate level for health professionals about understanding the implication of what they enter into our electronic medical records. At every time, understanding what's going to happen with that when it goes out the back door. Understanding critical, basic things. I mean, most of our healthcare providers are pretty bright. At the moment, they just have no idea what the implications of what they're entering are going to be. So simple 101 data literacy in undergraduate courses, and that's one of the great things of these platforms. They go across the university and they include undergraduate education. But also, once you're a health professional, a lot more understanding, and then we need a lot more people with data skills. If you have a son or daughter who wants a career right now, encouraging them to think about data is a very wise move. Unfortunately, my daughters are not at all mathematical, but I digress. So it's really important. We're going to have to import a lot of that expertise from overseas. So it is actually something that government recognises. The other thing we are desperately, appallingly poor on in Australia is implementation research capability. And that's a key platform for state and federal government to build that capacity and to start to transition perhaps some of our researchers who've had a more traditional track in training actually into those sorts of areas to be able to research with the capability to do the sort of work that the government wants to put an awful lot of money into with almost no one to deliver it in a very short time frame. So can I ask, is there anybody else who has any other comments? Jim?
Thanks, Linda. The data executive at the second meeting, we were asked to have a very quick look at what the priorities were for the executive in terms of the MRFF priorities, and they essentially came under two lumped headings, if you like. One was the development of a proof of principle integrative platform, like you talked about, and with that the requirement for a secure portal for a minimum core data set across all of the different systems, and improved capture as well as building of analytical capacity across the partners. And the second was then looking for...
That's a very big first. Really important, but lots of elements.
Yeah. Well, that was broken up into multiples,
Yes.
and I just coalesced it.
Yep.
And the second really was looking for targeted translation topics. And the most consistent one seemed to be interventions to reduce readmission in high-risk groups, of which the Department of General Practice Redirect program that you mentioned earlier was cited as an exemplar. But there are multiple others, I think, in a similar way occurring across the partners.
So that information that came from the data executive actually has already gone up to the MRFF team. So that's an example of how we can take a coalesced agenda that's come from that group and share it at a national level and say this is the way we can go. In fact, the shaping, it fit really well with the shaping at the moment, because it's clear there's going to be investment in infrastructure and systems-wide approaches, like the first one you talked about, and then exemplar projects that start to test and work and improve the areas that we've talked about. So those exemplars might be in diabetes or lupus or another area, But those exemplars have to be designed to test that system and improve the infrastructure. And that's the way it's shaping up, so that the way that was structured, Jim, fits very nicely with the approach that's been taken. Sorry, you had a question?
Yeah, no, it's not, it was a comment.
Yes.
I just wish to say that the Australasian College of Health Informatics, that I'll guarantee no one in this room basically heard of, will be starting a training program this year.
Terrific.
And we will be looking for partners to offer positions so that people will be trained as health informaticians.
We would love to talk to you.
Yes.
The beautiful thing about this is it's an incredibly collaborative space, and we are very happy to work with and talk to as many people who wish to collaborate as possible. Anyone else have any salient observations they wish to share, comments? Yes, Ross.
Perhaps just to make the comment around data and how it integrates into care.
Ross, if you can speak up a little bit so we can capture your question.
There is the opportunity around the Victorian Heart Hospital and the design of the systems that sit within that to try and build something advanced that looks forward rather than having to be based on existing systems, and be useful to have the various groups feeding into that.
That would be really useful. At the moment, actually, it's interesting because as I understand it, and please forgive me if I'm wrong because I only have a preliminary understanding of the heart hospital, but in my preliminary discussions, there was not even going to be the same platform that all the other health services are on. So that is interesting in terms of linking up. So definitely the heart hospital is a target because it's going to be a really good research vehicle. So the opportunities to make sure moving forward we have similar aligned processes and we're strategic about that is going to be really important. Susanna, do you want to make... Susanna Hearn, I'm putting you on the spot here. If your correct title, I believe, is that you're the head of the registry unit, registry science unit. I don't know if you have some comments you want to share with us about that sort of the systems approaches that are needed from a registry point of view. Just for those who don't know what a registry is, just if I digress for just a moment, and there are many world experts in the room in this area, so forgive me if I give you my interpretation of it. But essentially a registry is the platinum credit card of data. So it's pulling out the absolutely critical minimum data set, as John McNeil has educated me. It's the particular points that you would put your thermometer in into the plum pudding to tell you it's cooked. It's not the whole thing. It's about what you actually need to find. Many people are laughing because I've heard that before. It's what you actually absolutely critically must get in terms of very well-defined quality data that will allow you to be able to look across a very large cohort or population. Not every endpoint you want to collect, which is the temptation people put in there all the time, but using that data, making sure it's validated, making sure it's very high quality, and then using it effectively for benchmarking longitudinally and cross-sectionally and changing practice. So that's it in a very small nutshell. Did you want to make a comment about the opportunities to develop the sort of infrastructure and the science unit?
Yes, certainly. I'm not sure if this is on, but so previously registries within the school have been developed reasonably independently from an IT point of view. They've been supported by in-house development, but we can see the benefit in streamlining our processes and our infrastructure, and really from the whole way from data collection through to data management, through to data linkage, through to analytics, through to data sharing, there's the potential to develop some key infrastructure that can support all these activities across all our registries. I mean, certainly even very recently there's interest internationally from a range of organisations that are interested in having similar data sets or sharing data with us. So, and of course there's increased interest in things like PROMs, collection of patient-reported outcome measures as well. And so all our registries, we've got about 25 in-house, are sort of interested in developing this sort of capabilities. So instead of each registry trying to learn to do it on its own, we're interested in developing some key generic processes that can support the whole school in that area, in those sort of areas.
So again, that's a sort of systems level example that instead of everyone struggling to do it on their own with disparate processes, we bring it up to that higher level and actually use their expertise, but the similar processes in what we're doing makes it an awful lot easier. Any other comments, questions? Yes?
I suppose I'm going to go from the communication side. This is probably the major endeavour into the disciplines and across thematic approaches. When you sort of have a look at Monash Partners website at the moment, we're not up to date to 2015.
No, we're not.
So we've really got to concentrate hard on getting the communications out.
We desperately do.
What the core values are, particularly if you've identified
agree.
as a lead in here. So I'm stating the obvious,
Agreed.
but I just think we've really got to start getting it together.
So here's my only complaint for the day, is that is absolutely critical, and that's a message we've put back to partners repeatedly. The challenge is, and just to be perfectly honest, I do this job 2 days a week. We have a total of 1.6 EFT in a space that potentially is going to attract multiple millions and millions of dollars. So we clearly have to escalate that very quickly. And one of the first priorities, Matt, is effective communication, and the website is being revamped at the moment. At the moment, we can't even get into the platform to alter it. Otherwise, we would have done exactly that. But it is fundamentally important. So, I agree. And so does the comms manager, who's 2 days a week and only just started. Yes, John?
Elena, I don't think we should forget the fact that we need a lot of really simple things done to improve our data management capacity at Monash. And one of them I think Belinda would be very good to talk about, and that's a secure data portal, because we can't be sharing our data through USB sticks anymore.
It's actually, no, you laughed, Belinda, but I have to say, in fact, it's a really important point. When I've been spending quite a bit of time with my, if you can take that microphone in, with a lot of the early benchtop research colleagues who are starting to have increased access to and use of human data, they are walking around with it on the USB sticks, and they're walking around with it on their laptops. Having said that, the state government stores their data on hard drives under their desk. So we have a huge problem, because we will have a data breach, and somebody, the proverbial we, and it will be a very big problem, as it has been in areas like the UK. But that is a critical point, and being able to access systems like, hopefully Belinda's going to allude to here, where you can confidently as a clinician go into a system that e-research and the guys at Monash University set up, that you can go in, know that you can use the data safely, and for the data custodians to know that you can not breach the requirements. Do you want to say a few words?
Yeah. So I have an appointment with the Fire Institute in the UK. I work there on Fridays, except when it snows.
Hopefully not actually there, yes. Since it takes a week to get there.
You're just working in an entirely different environment. And I think fundamental to that is just the sheer amount of funding and infrastructure that's been put in place behind the Fire Institute. It is really a national approach that they've taken. Anybody with access to the various data sets, and we're talking about, I think one of the fundamental things we probably have to understand is that through the Fire Institute, what you're actually accessing is linked population level anonymised data, so you don't actually know whose data you're actually looking at. I think that's really important. But they also have a very strong infrastructure for anyone accessing it has to go through safe researcher training. And this isn't learning about ethics. This is learning about, how do you not breach privacy? How do you understand what privacy actually means? How do you understand what you can and can't access? And I have to go through that every 2 years, and they've built a beautiful online platform, and that differs if I want to access Scottish data compared to Welsh data or English data. So there's all that infrastructure in place, but fundamental to that is really just these safe havens where you go in, you're working within their system, everything around the projects, everything around the data, everything is in that system. You cannot take anything out. You cannot take a file out of the system without approval from above. That could be a PowerPoint file, it could be a data output file, it could be anything. So nothing walks. But on the upside to that is that you're actually working basically with a supercomputer behind you. So the 9 hours it takes me to run a model for an annual report for my registry, I can do in their system in a matter of minutes, because you've got that infrastructure actually behind you, which we just don't have here.
So along with the weather from Manchester, we're actually hoping John will bring some of this.
Look, I work for Swansea University, and it's the rainiest city in the UK, so
very nice.
I don't think Manchester.
It's actually a quick day trip from London too. So. So I think the point is there's a lot of opportunity. Obviously, de-identified data is useful to many of us, but actually many of us also want access to identified data, especially in terms of healthcare improvement.
That changes the level of
absolutely data security
complexity that we're talking about in the systems.
Hugely, especially when you want to link it. So I think that there's some critical issues that we need to understand there. Any other contributions, comments? Yes, Danny.
Well, have we engaged at all with the Victorian Agency for Health Informatics, that new data sort of group?
I have met with the multiple groups so when you say we, all I can answer is from my personal perspective, Danny. I'm sure there are others who've done this, but it would be fair to say that I have met with the many different people involved in data in the health department, and as many of you who deal with the health department know, they often don't speak to or communicate well amongst themselves, and often the initiatives are very disparate, they're non-strategic. They need an academic health science centre in the health department. But yes, I've spoken to many of them. The turnover of those staff is astounding. The ability to actually create a rapport and actually pull something out is difficult. But our approach is that we're working with Safety Care Victoria, which will be clinically led. So Ewan Wallace, Andrew Wilson, who's the new Chief Medical Officer, and Anne-Marie Kernan are going to have a very strong influence around what's going to happen moving forward. And the proposal that we have put to them is to create a platform across the 2 academic health science centres and Safety Care Victoria to be able to do a lot more of this work around, because we're not the university, we're not the health service, we're the partnership about better patient outcomes, and potentially that might work slightly differently. So at the moment there's significant interest in that, but who knows? So that's the short answer to that question. If you have a better way of working with the department, please let me know. I don't know, Ian, whether you want to make any comments about some of the major disasters in the UK that we perhaps would want to learn from and not repeat. Do you want to make any comments? But Ian is from the business school and has had a long history in health and digital health in the UK and elsewhere.
I want to travel back there in about 2 months, and I noticed there's people from the UK in the room, so I don't want to... But Australia hasn't got a clean bill of health either on that front, so it's not... it's just a very difficult area. And I think having the mixture of people you've got in the room is extremely important, because it's not just a clinical problem, it's not a technical problem, it's not a political policy problem, it's all of those things. And you need collaboration to try and work through. And I think when the things have gone wrong, it's because they've been driven by one set of interests. And, you know, the National Programme for IT was a very commercially, private sector-driven set of thinking. It didn't work out. So I think the more collaboration, the more all the stakeholders are involved, the better. Doesn't make it any easier to get agreement.
Was it not an astounding failure?
Well, there are different views about the degree of the way things went wrong.
And the money.
And there's been lots of data breaches. But there are problems here. The thing happening with I won't say job centres, the...
Centrelink.
Centrelink, things that are going on. The issues last year with the national census there. So, you know, these aren't sort of specific to one country. I've still got a British passport, so I have to be careful. But,
they might evict you, yeah. No, but the point is that they've got a lot of learnings that we should leverage off in our journey.
I thought I might add that while we're waiting to get... Oh, sorry. Hopeful for the extra funding from MRFF, it's worth making use of some of the funding we do have available at the moment. So we've got the MIME seed funding for digital health projects, and that's about to open again. And there's
actually, can I ask you to take a step back and just give us a very quick snapshot of MIME? Most people in the room would... Who knows what MIME is? So not everyone. Can you give us a little snapshot? Because, to be honest, I think the thing about MIME that I find very inspiring is it's trying to do exactly what the academic health science centres want to do. It's getting that pull in a very literal sense. So do you want to give us a quick...
Yeah, so MIME's a relatively young institute, and it's involves all the partner hospitals that are in the Academic Health Science Centre, Monash Partners Academic Health Science Centre, and the university, plus CSIRO, and it's about clinician-led technology innovation, and that can be devices or diagnostics or digital health, anything where there's a unmet clinical need that needs an engineer or an IT or a scientist or a design person to come in and provide that complementary skill set. And so we have a seed fund that's been made available by the Faculty of Medicine and the Faculty of Engineering, IT, and some of the hospitals have chipped into that as well. And so we put a call out every year, so there's one about to go out now, asking clinicians where are your unmet needs that need a technology solution, and that covers the digital health as well. And then we have small amounts of money to kick projects off, about 50,000, but cumulatively it adds up each year to about $1 million in funding for new projects. But the reason I asked about commercialisation is now we're getting investor interest from the first crop of projects that went through, and we have potentially up to 10 million to take projects that graduate out of the seed fund through to a full commercial product development. And that's so that we have something not only that the partner hospitals can use, but also someone to take it forward and make it available nationally or even globally if it's relevant. So we're new, but it's evolving well, and I think it's useful to use that as a complement to whatever other sorts of funding we're able to attract from MRFF or anywhere else.
It's a really good example of collaboration, actually, and of the pull that you describe. So very valuable. Any other contributions, comments, concerns? No? Yes, John.
Just one brief thing. Elena, we've in the School of Public Health been really tossing up whether there's any value in moving in with or collaborating with a commercial partner, someone like Oracle or SAS or whatever. It'd be interesting to know what people's views are about that.
Yeah, so that was in the context. So John was talking about partnering with commercial entity to do work that we actually are not necessarily so well positioned within the university to do, like very complex trial design databases and the registries. Yeah. So that's something that I think is on the table because of the frustration of being able to get the platforms and systems that are needed. So maybe you can have a chat to John too when he gets here. But I think, was there anyone who wanted to make any observations or responses around that? Okay. So I think you're probably leading out the front there, John, so we're probably all going to play catch up. So can I ask, is Lyle Turner in the room? Lyle, thank you. You're here on behalf of Daniel Massa, is that right? Can I ask you just to briefly describe a little bit about the primary care group you're involved in, the sort of data work that you do and the access that potentially, the opportunity that's potentially available moving forward, just to give people a bit of an example of the work. Jim's been specifically working in collaboration with you and has done a lot of work with the data that's available around vaccination and health. Do you want to just give us a...
Yeah, so Jim mentioned the linkage. So we've had, for the last few years, we've had the Magnet project running, which was a collaboration with Inner East Melbourne Medicare Local, who became Melbourne East GP network following the PHN splits. And so basically, yeah, we utilised routinely collected GP data for research, but a recent addition to that has been the capability to do data linkage, and we had a number of projects funded last year where we worked in collaboration with Eastern Health, examining so it allowed us to examine across primary and acute care and the GP management and how that related, particularly in older patients with chronic disease, how that related to their utilisation of ED attendance. And independently, Melbourne East GP Network have also done some work around risk prediction, ED attendance, things like that. So kind of in the same space as the Redirect project that was mentioned, looking at strategies to keep older patients out of ED by redirecting them to primary care. We can see there's a lot of potential in the kind of the linkage capability that we've created, and certainly we're in discussions with Monash Health and Eastern and early days with some of the PHNs around pursuing more projects utilising the linkage capabilities. So
the critical emphasis there is you've created, and I mean the big point is everyone talks about the fact that we want to do this, but the fact that there are exemplar projects that have done it and that can inform more broadly actually becomes really important.
And I think it's important. Chris just left, but he's one of the drivers of the whole the data collection that IML and MEGPEN ran, and it goes back to the division of general practice days, and it's based around quality improvement, feeding back to practices. But I think the expertise that we've built up as the Magnet team over the last few years, even though the whole Magnet structure is changing now because the PHN system's a whole new way of data custodianship and things like that. That expertise is really critical, and I think it can be. There's a lot there that can be utilised going ahead with the Monash partner, MRFF applications and things like that. So
it's very exciting. So we're going to look to Eastern around the opportunities that you've created and look for some of our other partners to be able to emulate, contribute to, streamline alongside. One of the challenges, of course, is the politics around the different databases, who owns the different databases, and the two universities, and the fact that that's actually quite integrated. So some of that work we may end up doing in partnership with Melbourne.
It's probably worth pointing out that what Magnet's done locally and we can do intensively either at Monash Partners or in conjunction with Melbourne can be translated nationally, because the NPS runs a very similar extraction progress across about 500 practices nationally, and so it's almost immediately translatable.
No, but I mean, those sorts of exemplars are really important, and being able to invest in infrastructure to bring those exemplars to fruition is the sort of thing we do. The other thing is I'd encourage our early translational researchers to think about what they need in terms of data. As I said, there's a very clear need for data education. And that will be one of the things we're putting to council around the next critical thing. So we've got a good clinical practice training program around clinical research that's freely available to all of the members of the partnership. But the next thing the next cab off the rank is almost certainly going to be around data from 101, data integrity, through to more sophisticated opportunities. So that's important, yes.
One thing we haven't mentioned today is genomic data.
Yeah.
I think we need to have a position for that.
I mentioned it only once in the huge exemplar of success in the lab in the middle of the School of Public Health at UCLP. Yeah.
Just that it's a large growth area, very challenging to manage large data sizes, but a kind of critical need to integrate it into medicine. So I think we have a lot of opportunities in that area, but probably a little bit underserved in terms of our ability to actually execute on that. So we should maybe think about how we can do that going forward.
Great. So these are the sorts of things you need to think about, how you're going to do that moving forward and who you need around the table. One of the things, just before we get to the next question, is before I walk out of here, a lot of the conversations I've been having with people when they say, well, what sort of things might be relevant for the MRFF? I've got all these projects. And I've stopped them before they've told me about it. I said, stop telling me what all your projects are. That's wonderful. Tell me what the biggest priority area is in your area of expertise. Tell me about how you would give me a structured case around why this particular problem is really important. So I asked them to start thinking about it from the front backwards. Likewise, if you're all sitting there thinking there's a particular area I'm really interested in that could go very well on this platform, not just for MRFF funding, because honestly, for example, a philanthropic partnership that's on the table is multiple millions of dollars a year for many years. It's a tender process. We may not get it, but if these sorts of things come out, they're not small pots of money. So start to think about what you're doing, like this example, with how you would frame that this is a really critical priority. How would you demonstrate that it aligns with the national health priorities, the critical need for infrastructure, those sorts of things. And if you start to think about the work that you're doing and the collaborators you need to have and how you bring that across the partnership, you're going to be getting yourself on the journey towards the sorts of things that are going to be needed when the opportunities drop. Yes?
I just wanted to follow on the genomics question. There are frameworks at the state and federal level to capture genomic information in a uniform way, and two organisations leading that are the Australian Health Genomics Alliance and also the Human Variome Project, which is actually based here at the Hudson as of last year. It transferred from Melbourne Uni, and I'm the national director. It's a UNESCO-affiliated organisation with 3,000 labs in 81 countries, and the infrastructure is very, very solid there, unlike the Genomic Alliance. But at the global level, there's Global Variome and the Global Alliance, and these two organisations, along with several other international organisations such as Hugo, are now talking about and getting memos of understanding. It's very important, particularly in rare conditions, that we capture global information, and the discussions are at hand now to capture the national, to make it mandatory that data is captured from clinical genetics labs into a database. And here at the Hudson, through the Human Variome Project, we're part of that initiative.
Spectacular. I didn't know about that. Can you send me personally a brief description of that? That would be really terrific. Thank you. Anything anybody else wishes to share? Any other questions or compelling messages that you think are critical that we need to know moving forward? All right, I'm just going to say, can you keep your mind open around the question that Ian put to you about what sort of representation you need to inform the university about their potential move forward? And And then the other thing is the data executive who are in the room are now going to meet after our discussions and just firm up some of those recommendations and suggestions that are relevant in terms of consolidating the discipline in principle areas that we want to move forward on. I'd like to pick up on what you've just brought up too. And we'll also bring up the issue about capacity building and the need for data, and we're already across the issue about security and potentially about strengthening infrastructure around registries. But if anyone has anything else really compelling, big picture, high level, compelling messages that we think need to be part of data moving forward or a data strategy, make sure that you at least let us know. To give you any confidence, I'm not in any way proposing to be the person that writes or puts forward whatever our strategy is, but I am going to bring all the right people together to be able to do that. Okay, thank you very much for your time. Great to see a good turnout. Thanks to Brendan, because we now know it's going to spread a lot broader than just this room. And we will keep you posted as things evolve. And thanks to everyone who's come from off-site. There's people from all over the place.
Thanks for listening to this Monash Partners Data Forum podcast. If you'd like further information about Monash Partners and the work we do, please don't hesitate to call Gillian Chamberlain on 03 8572 2627 or email Gillian at gillian.chamberlain@monash.edu, and that's Gillian with a G. Thank you.